Hi, everybody. It's Professor Spears, and I'm very pleased to welcome you to another episode of Human Services Porter County. And in honor of National Suicide Prevention Month, it's my pleasure to welcome my colleague and friend, Rachel Drosdick-Sigafoos. We were colleagues on the board of directors of the National Organization for Human Services, and she's got a very impressive bio. And I usually don't like to read to people, but she's got some really interesting things here. So I am going to do that, and hopefully I'm going to get all this right. Rachel Drosdick-Sigafoos has seen suicidality from all perspectives. As a suicide loss survivor, as a person with lived experience, and as a crisis clinician. Dr. Drosdick-Sigafoos proposes to approach suicide risk identification and prevention through a dignified human approach, honoring how humans are neurologically responsive to co-regulation and connection. Dr. Drosdick-Sigafoos has worked with children and adolescent populations and the veteran population, and earned a PhD in human and social services with a specialization in disaster, crisis, and intervention from Walden University, with her dissertation titled Hope's Moderating Effects on Crisis Workers, Meaning in Work and Turnover Intentions. She served as the Susquehanna University's interim head coach of men and women's swimming and diving for the 2023-2024 academic year. So welcome, Rachel. I'm really
Thank
happy
you.
that you're here. And I like that in your introduction there, that you talked about, well, and it's in your dissertation, hope.
Mm-hmm.
That's something that so many people struggle with. And uh, it seems like we've got such a societal deficit in feeling hopeful. People have
Mm-hmm.
talked about how I don't know if I want to have kids because the world is messed up. And
Yeah.
so it's affecting people in the lives they're living now and what they're planning in the future.
Yeah.
So we most certainly need people like yourselves and so many others who are working to improve quality of life and
Mm-hmm.
joy, which I think is also very important. But if you could talk a little bit about your work, where you're at and what you're doing,
Mm-hmm.
and fill us in, that would be wonderful.
So I've had a strange career arc that has now come full circle. Um, I was a college athlete and transitioned into being a college coach. I loved coaching. I loved being an athlete. It was such an important part of my identity. Um, Coinciding with that, I began experiencing symptoms of depression as a young adolescent, age 12, 13, and I was definitely having passive suicidal thoughts as a teenager and onwards. Now, passive suicidal thoughts are thoughts like, I think about dying, but I'm not thinking of doing anything to myself. It's more like, if I get in a car accident or something happens to me, I'm okay with that. However, after years of therapy and being on medication and really developing a very good sense of stability with my mental health, in 2015, I was driving to a meet and I got in a car accident and I sustained a very serious concussion. Now, one of the conversations around concussions is that they can cause changes in thought and behavior, and that one of the markers that can come up, although it's not discussed enough, is suicidal thoughts and behavior. My previously well treated, very much stable mental health went off the chains when I experienced that brain injury. And within 2.5 weeks, I had identified a plan for how I was going to end my life. And the only thing that had stopped me was there were a couple, but now this is important to note. My brain was unwell. I was not well. So I can say with retrospect that I know that these were not rational, truth-based thoughts, but I thought the people in my life would recover. I thought that my dogs would not understand. Additionally, the plan that I had identified would have exposed other people to trauma in finding me, and I didn't want that for them. I was very lucky in that because I had so come to peace with my own death, I was talking about it as if it was what I had for breakfast 2 weeks ago. It was boring. It was unexciting. It was uneventful. There was no fear. There was no shame. There was no nothing. And nor should there be shame under any circumstance around any conversation. But all that said, I was just talking about it with people. And some of my very close friends and colleagues intervened on my behalf and helped get me inpatient. However, through the course of that, I did go through a couple of different crisis units. And one of them in particular was incredibly dehumanizing. And I left that experience really thinking, and there's a whole backstory that goes into it, but essentially, I had to take off all of my clothing and I wasn't even allowed to keep my brassiere on. And there are reasons for that, but for a female, that's, you don't go out in public without that garment. I wasn't allowed to call my husband. So I really was feeling alone. I was locked in a room by myself, and there was a babysitter who was maybe old enough to drive, but probably not much older than that, who was outside of my room. And I was feeling very alone and very frightened. And in the middle of the night at that crisis unit, a man was brought in and he was put in the room across from me, and his door was allowed to remain open and he was permitted to keep his clothing. And through the course of the night, eavesdropping on that conversation, I discovered that he had killed 2 people that night. And I left that experience thinking, I came here for help. I came here for assistance because I was frightened, and I got treated worse than a double murderer. Surely that means I need to die. Surely that means that my life is not valuable. After that, I was connected with a much better crisis unit and transitioned into a brief inpatient program and subsequently to back to outpatient, and rediscovered stability. But it was a road to recovery because I still had that brain injury. I still had the predisposing factors. So there was a lot of recovery that had to happen. Once I got healthy enough, though, I really looked back and thought, I can't know that this is the condition of crisis and what is the worst day of somebody's life, and do nothing with that. So in 2015, I began working in behavioral health. And in 2016, I got my first job as a mental health crisis worker, which I did from 2016 to just this past week, actually, was my last week in crisis. And now I am, just for an interim academic year, going to be Susquehanna University's head swimming and diving coach. So we're back into that world now.
That is an amazing story. And while I 100% agree with you that there should never be any shame in talking about our experiences and our struggles, we still face people who will look at us and judge us and think that we're, the word that I absolutely hate, that we're crazy or just seeking attention. And that makes it so difficult to talk about. And for you to go into the level of detail that you did here in a public forum, I mean, I really appreciate it. And I think that it's going to be very empowering to many of the listeners who take a look at this video and they can
Yeah.
think, if this woman who's really come so far personally and professionally has been able to do this, so can.
Hmm. Yes.
And, something that struck me about your story, there were many things. First of all, I did not realize that there was a correlation between concussion and
Hmm.
suicidal ideology.
Yep.
And also what you commented on, that the person in the room next to you had just killed two people and he had an open door and all of his clothes on, and you were not allowed clothing and your door was locked.
Hmm.
And that, I think it's another reflection of the way in which they, meaning the system, even in healthcare, uh,
Hmm.
you use the word dehumanize
Hmm.
people who are going through crises like this. And I think it explains an awful lot of the reason why people don't go through seeking assistance, because
Yeah.
you fortunately, your first experience, while it was bad, you did not give up and you
Yeah.
you sought help from another place. What are the risk factors for people? Uh, well, what interests me most at the moment after your story is you were talking about suicidality in your
Mhm.
thought process and how there were various factors that prevented
Mhm.
you from following through.
Yeah.
Can you explain for us what it is that would take many people from ideology to active attempts?
So the pathways are very diverse. One of the most important things to note is that, generally speaking, suicidal thoughts they can be chronic. Certainly within my veteran population, I talk with people who say, I've had suicidal thoughts every day for 45 years, but I have no desire to act on that. Suicidal behavior, attempts, and deaths generally are very time limited things. There is a very small subset of the population who is at a chronic risk for suicidal behavior. More commonly, though, people have suicidal plans and attempts and deaths for very short periods of time. And this, a lot of it is based on our neurology and on our physiology. That when you think about what's called the arc of the crisis, there is a period of chemical escalation that's happening that feeds that suicidal behavior, that kind of brings you off of your sense of rationality. If you can help a person ride that out and they come back down the other side, as was done with me by my friends, the people who helped me, there's many people never go back to that place. They never go back to that place. Or if they do, they have a better understanding with the correct treatment and approach and methodology and everything, not just in a treatment setting, but also in what they do for themselves and their supports in a daily life. They can recognize the warning signs. They know what to do. They have a safety plan. In terms of the risk factors, though, a really big part, you mentioned that lack of hope. When you think about suicidal risk, one of the major components is tunnel vision. You can't see, hear, recognize any potential for not feeling trapped where you are right now. Most people, when they really reach the arc of that crisis, the top of the crisis, where they're at a very high degree of risk, is because they are in that moment feeling there is no relief, there is no comfort. This is my sentence, so to speak. And I do call it a sentence because that's how it feels when you're in that moment. When it was happening with me, I was dealing with emotional pain, I was also dealing with real physical symptoms of the concussion. And so I had this just, I mean, massive headache is not enough of the word, because I couldn't be in a room with lighter sound. So I had no connection with other people. In a lot of ways, that experience as a physical is how many people, even without a physical malady that can predispose them to suicidal risk, that is what it feels like. There is no light, there is no sound, there is no hope. And so you get into that tunnel vision. But if you can help someone get through that component, get off the top of that chemical arc of the crisis, they may not go back to that space.
Can you describe for us, just going back to your personal experience, because I suspect it's far from an isolated case. It
Mm.
probably describes an awful lot of people's
Mhm.
experiences. Thank goodness for your friends and that they were not
Yeah.
ones where, yeah, a lot of people, they hear somebody talking about the things that you were talking about, and they'll say, yeah, I don't want to hear about that. I want
Mm.
to have a good time, and,
Mhm.
we'll just let Rachel work through her things. She needs a little time to herself.
Yeah.
What was it? Uh, Explain what your friends did and how they knew that they needed to take action.
So the folks that stepped in on my behalf, one of them was a psychiatrist. I happen to know her through coaching, actually. She wasn't practicing at the time. She was working in research, but she had been a psychiatrist, so she certainly knew the risks. And one of the others, her husband had had a history of suicidal thoughts. So both of them had enough knowledge to really understand that the degree that I was talking about, it was important. Earlier, you used the phrase, and this is a really big thing for me. You use the phrase, well, they just want attention. Absolutely. Humans desiring attention, this is a base human need for us. We do require attention from one another as a way that we stay alive. When you talk about babies, infants who are not attended to properly, that they're at a very high risk, even if their physiological needs, so they're eating, they're sleeping, they're being cleaned up on a regular occasion, even if those things are met, infants who are not emotionally attended to have a very high risk for developing all sorts of physical disorders, because our bodies require attention and connection from other people. I know somebody who I worked with in the child adolescent group. One of the therapists would say, using the term attention seeking is a slur. And I think that's a great way of looking at it. Because why are we trying to pile shame and judgment on something that is a core human behavior? And in fact, someone is more at risk for suicide when they have stopped asking for attention, because they're demonstrating that they don't have hope that anybody is going to respond to them to connect back with them. So what my friends did was not just identify the need, but also identify that this was not quote unquote attention seeking behavior in the way that you will often hear that used in behavioral health and human services. It was me crying out and saying, I am missing something incredibly important in my life.
You were so fortunate to have somebody, among your
Mm-hmm.
peer group who had that
Mm-hmm.
expertise and experience to be able to recognize that it's not being melodramatic. And I think
Mm-hmm.
when you were talking, when we were discussing the attention-seeking behavior, I think a lot of people view that as this is just somebody being, you know, melodramatic, and they just want things like they're um just fixated on themselves, and
Mm-hmm.
they want everybody to think poor me. But when you were talking about infants, we've got the
Mm-hmm.
failure to thrive. So
Yes.
it is I completely agree with you. It goes beyond just psychological issues
Mm-hmm.
because
Mm-hmm.
these are children who aren't eating, they're not
Mm-hmm.
meeting their milestones
Yes.
and so forth. So, and it likely has a lifelong impact, or
Yeah.
certainly puts them at a position where they're playing catch up for quite a long
Yeah.
time.
Yep.
And there's been a lot of research about that. So I'm glad that you uh, addressed the issue
Mm-hmm.
and kind of reframed it where
Mm-hmm.
it took away uh, the stigma and
Yeah.
said, basically, if people are seeking attention, why not give them
Good.
attention? They're seeking it
Yes.
because they need it.
Yes. Yeah. If somebody came to you, and coming back to the medical model of crisis assessment, and working on the other side as a crisis clinician, I fully believe that this is what happens. If somebody comes into the emergency room with a broken knee, they tore their ACL, or they shattered their patella, whatever it is, their physician and treatment team does not look at them and say, this is who they are. They say, oh my goodness, you shattered your patella today. However, because there's a high degree of compassion fatigue that comes along with seeing clients in crisis, I think that a lot of professionals begin to look at I should say us, as this is who they are. That was not who I was. That was me on some of the worst days of my entire life. That was not a representation. And just for the folks that this is who they are, they are not experiencing joy and fulfillment in this. And so to treat them as if, well, fix yourself. I promise you, if someone who is chronically suicidal, chronically they're experiencing severe mental illness, um, they're not glad about that. If they had the ability to fix themselves, I promise you that they would have. If I had the possibility to not choose to feel how I felt, I would have.
Yeah, I think most people, even those who are not in the helping professions and have higher education and training in that, can relate to nobody wants to feel horrible.
Right.
And I would hope that a lot of people understand that and something else that kind of sticks in my craw is people saying that suicide is the easy way out and
Mm,
that it's cowardly.
mm,
In my mind, and I'd love to hear your thoughts on this, but in my mind, it's people who are so desperate they don't see
yeah.
any other way out of the pain that they're feeling.
Yeah. Yep. Um, the veteran population, I would hear that a lot. And it was kind of unusual because for some people that was actually a protective factor for them to think like that. It was a protective factor for someone who had, especially if they were career military, to say, well, that's the easy way out, because they have sort of spent their whole life not taking the easy way out of anything. So for some people, I was hesitant to address that and really say, that's not how it is. But my personal loss that I experienced in my life, which was family members, um, that wasn't the easy way out. He did not feel that he had an alternative. And so to chalk people's worst day, their final decision, as the easy way out, I have spoken to, at this point, thousands of people who are at severe risk of suicide. They're terrified. They're terrified. And minimizing that only isolates them in a way that makes them more likely to die.
That's a good point, because at the time where they really need support the most,
Yeah.
and if they have well-intentioned but
Yes.
uninformed people around them
Yeah.
who are really blaming and making them feel guilty, it seems to me that it would give that person
Yeah.
who's struggling, and whether they can survive or not,
Hmm.
it just gives them one more nudge towards suicide.
That's right. I'm a QPR gatekeeper trainer. And one of the really key things that we talk about when somebody discloses, I don't know, sometimes I just think about not waking up and how nice that might be, or I just think, when, if I don't pass this test, or if I don't get that job, and so you can hear this tunnel vision language. Um, if I'm going to end my life, or even I'm going to go home and I'm going to do it today. One of the things that's really important is don't be stupid. I don't know why at any of the worst moments of somebody's life you would find a reason to insult them, but I can assure you that is not supportive. If they're telling you this, the correct answer is, man, you must really be going through something so difficult that you feel like this is your best option. What do we do? How do we get you help? What do you feel ready for?
Mhm. So for those who are not professionals in the field,
Mm-hmm.
and you hear somebody that you know, either it's somebody that you're very close with or more of a casual relationship, and you hear them talking about suicide, what are some of the things that would give you an indication that this is something really serious and
Mm-hmm.
I need to do something more? And then what does a lay person do?
Mm-hmm. Um, I think it depends from person to person. Just like speaking to somebody in a foreign language, it's going to depend on your ability to make some translations. Or, can you run a 5K? Can you run a marathon? It really depends on the person's comfort level. At the very least, if you feel very uncomfortable, somebody has said something really serious to you, um, my go-to recommendation phrase is, wow, I hear how badly you're hurting, and I definitely want to be here to support you for this. I'm not sure how much help I can give, but I will stand with you. I will drive you to wherever we need to go to get you help. Because what that does is, step one, wow, I really hear how hard this is for you. You validate that you've heard what they said. Step two, you've stated your position. I don't know how much help I can be, but I'm going to be here for you. I am not leaving you alone in this. And step three, how do we get you to a place that you can be safe? And then it's, is that somebody that is a positive support to their life. It's really important in these conversations to not suggest too much without knowing the background really well. So to say, let's call your spouse. Well, what if the stress on that person at that moment is their spousal relationship? Let's call your parents. What if they've experienced emotional neglect or other abuse by their parents? Let's call your psychiatrist. Maybe the psychiatrist isn't open at that hour. Let's take you to church. There's a million things that people might recommend because they themselves would want that to be what happened, but might not be right for that person. So asking, where can we go to get you a little more help, gives them the ownership of that, because and really ownership is such an important part.
Mhm.
A lot of people begin to think of suicide because they feel like that's the only thing that they can control. So giving them ownership then about, where can you go? Where can I go with you as a partner, as a support, gives them ownership over choosing how they feel better too.
I
It's
re
providing an alternative.
Yeah, I really like that because I'm always telling my students find ways in which you can empower your clients.
Yes.
And even in their most desperate times like
Hmm.
this, it's great to hear you mention look for ways that you can
Hmm.
give them choices and that you're going to be there to stand by them.
Hmm.
Now, going in the totally opposite direction,
Yeah,
because we know that there are cases where people are held against their will.
sure.
Can you talk about that a little bit?
Yes. So there are many different terminologies. State by state, they all have a different name because they all fall under a certain state regulation. But the most basic phrase that you'll hear is an involuntary commitment. There are a lot of misconceptions about involuntary commitment, both about when a person can file for an involuntary and what the procedures are after that had happened. So I live in have done treatment in Pennsylvania, but since the Veterans Crisis Line that I was working with was nationwide, I was somewhat familiar with how it worked in most states because there were times that I was peripherally involved in accessing that as a resource. Excuse me, sorry. Um, so the involuntary commitment is a civil warrant. That's important. It is not a criminal warrant. It is a civil warrant that is just giving permission for a peace officer of some sort to help get you to an emergency room. It is not, first and foremost, you're automatically going inpatient. But there are certain conditions that are required to be met in order to qualify for someone to even compel a person to a civil warrant for involuntary commitment. Those are immediate risk of lethal means and intent to harm themselves or others, or they have reached a point of real incapacitation where they're not able to care for themselves. Having said that, it is extremely difficult to prove that somebody is not able to take care of themselves. When we're talking about that as a set of grounds, we're talking about maybe 1.5% of the entire American population that can reach that level of mental illness. And you're talking about years of psychosis. So we'll kind of, that is a component. But state by state, some people think, well, if I get an involuntary, they're going to automatically take away my guns. That is not necessarily the case. That is very much dependent on what the conditions were for why somebody was compelled to an involuntary evaluation, and what happened after that point. So in Pennsylvania, the first part is called a 302. The involuntary commitment and assessment is called a 302. If you get recommended for inpatient hospitalization from that, you have the option to sign yourself in. What most people don't understand is that there is then a separation between I can sign myself in and have myself, like I'm responsible for making this decision, or I'm going to be put in for it. It's the latter usually that becomes involved in like firearms ownership, having a job in law enforcement, serving as a security officer, things like that. And then it can go onwards past that. Having said that, there are a great deal of ethics that surround an involuntary commitment, and that is a conversation for like 3 other podcasts because it would be wading through an absolute swamp.
Yeah, most certainly, because we all know that
Mm-hmm.
one of the items that are in every professional organization's code of ethics is
Yeah.
autonomy, and
Yes.
when
Least restrictive, least intrusive.
exactly, and this is the absolute opposite of that.
That's right.
But sometimes it's necessary, and I've
Mm-hmm.
been involved in a number of cases where I've been the person who has
Yes.
initiated the
Yep.
process.
Yep.
And it's a tough call to make
Mhm.
because you
Mhm.
know after a certain point it's out of your hands because it goes to uh, I have spoken with the psychiatrists and provided
Yeah.
them with the information, and they call, and I can only speak to Indiana, but they call the judge no
Mhm.
matter what time, day or night. And
Mhm.
once the order is made,
Yeah.
it doesn't matter what anybody says or promises or anything else, you're going in.
Yeah.
And it- I I've had to do this, like I said, for three or four occasions. And what I have found most distressing, and I personally feel that there has to be a better way of doing
Yeah.
this, because after the order is made, it's police officers who go,
Mhm. Mhm.
and I've been involved in cases where somebody was in their apartment
Mm.
and it was late at night. So,
Mhm.
of course, it's dark. All
Mhm.
the police cars with their lights going on gets everybody's attention. Everyone's peeping out their window. And obviously, the individual's not interested in going.
Yeah.
So they're
Yeah.
resisting either physically or trying to reason their way out of it.
Yeah.
And they explain the process. And even though they
Mhm.
explain it, that doesn't really help all that much. But
Mm.
they put you in handcuffs behind your back and they
Mhm.
put you in the back seat of a police car as though you're a criminal.
Mhm.
And, that of course gets the attention of everybody. And even when things work out and they decide short of the 72 hours that you're safe to be on your own,
Right.
you go home and people are either
Questions.
just looking at you, like you're a criminal or a crazy person,
Mhm.
or they ask very intrusive questions. And there's
Yeah.
just got to be a better way to handle that, because we're taking their autonomy away and their dignity
Mhm.
as well.
Yes. And the dignity is such a huge component. So I think that this is a key plug for 211. 211 can be accessed pretty much nationwide. It's going to connect you with a local helpline, and your helpline is going to know what the procedures are and who to call. One of the components that a lot of lay people aren't familiar with is asking about mobile crisis. Mobile crisis is being expanded more and more. It is more difficult in rural areas. However, in many areas, and some rural communities included, the difference there is the amount of time it might take to get there. They can have a mental health team of people go out and meet with that person. They knock on the door. It's usually a team. It's usually two people, but not always. Um, to come out, and they're gonna talk with that person. Just, hey, what do we do here? Now, the limitations to mobile crisis are if that person has a weapon and they have access to it. And when I say access, I don't mean like there's a knife in the drawer in there. I mean like there's a knife sitting next to them or in their hand. That's going to be a time the mobile crisis will say we can't go out because that's not safe. Um, but for a lot of those cases where someone's first thought is I'm going to dial 911 and then police go out and then it becomes what you've just described, some of those can be headed off by calling 211 and asking about mobile crisis resources. Um, what I think one of the really challenging parts with our law enforcement, and there are departments that are working so much more on getting a mental health liaison that is responding with them, who is able to do so much of that de-escalation. And a lot of police departments are working more on their own de-escalation techniques, relating with others. I trained CIT officers, which crisis intervention training for police officers, that should be a requirement nationwide, all officers, full stop. It shouldn't be an opt-in. It shouldn't be that every department we're going to ask, or every year we're going to ask your department to send 2 people. And somehow it winds up that it's either the same 2 people or go or nobody goes. Because some people, we just don't need it. But law enforcement is trying to get better. But it's coming from a very different perspective. I can tell you, because we worked so closely with law enforcement with Veterans Crisis Line, and because a very, very high percentage of our veterans who were calling, they had access to lethal means, I mean, out the wazoo, and they know how to use it. And their safe storage methods are like, it's under my pillow, which for what it's worth is not a safe storage method. So it changes the conversation. And so those are also times that if you as the outsider, if you as the person who's calling for assistance can give the most information possible. When Veterans Crisis Line called for assistance, we had some departments who were so great, they would say, we have an Army veteran or we have a Navy veteran who's on right now. We'll send a veteran out to talk with them, because now they're sending that shared experience out. If you tell them these are the predominant, these are the precipitating circumstances. They're going through a divorce. They just lost their job. They have a physical injury. They were diagnosed with a terminal illness. Their father just passed. It helps bring a fuller picture to what's going on, so that de-escalation can happen, as opposed to they live at 123 South Road, and they're suicidal, and then you hang up the phone. Give them as much information as you can, because they can then use that information to help keep that person safe in a dignifying way.
And I agree with you, and the evidence supports that police departments are recognizing that the use of force is not always the best approach to take. It can be related to suicidality or people on the streets with either dementia or autism or something else, and they don't follow orders. And I have to say that just in the last couple of days, one of our local police departments has hired an MSW to be part of the department. Yeah, I think it's wonderful, but they wrote a really nice article in the local paper, which was, of course, available online. And I try to make a habit of not reading the comments that people put. But some of my former students that I've maintained friendships with since then had mentioned on social media how wonderful it is that they've hired this person, but I've looked at the comments and there's just so much ignorance and anger, and they're feeling as though it's taking away resources from law enforcement, and that's where the money belongs. And just some of them were just so vile in what
Can
they
I hit the
were saying.
timeout on that one?
Yes.
So my response to that is always that a law enforcement officer, as well as firefighters, are more likely to die by their own hand than in line of duty. So at the very least, having an MSW on staff may help keep your police officers safe from acting on it themselves.
That's an
If we're
excellent
worried about our
point.
rescuers, then let's care for our rescuers. Let's give them the resources. Because our
Mhm.
rescuers, EMTs, firefighters, our first responders, they go through an awful lot. And they are, as a group, one of the highest at risk for suicidal thoughts and behaviors. So if we can bring a person on staff who is also familiar with how to recognize those concerns,
Mhm.
even though they're not there as an EAP counselor or something like that, they still are going to have the ability to recognize a risk and know how to speak truth to it.
I agree with you wholeheartedly. And the people, it seemed, who were most upset about the hiring of a counselor to be in the police department, they really seemed quite dismissive of social workers and counseling
Mm-hmm.
being involved at all, because, we've got this in our country, this mentality of it's law and order, and, that's the approach to take, even though, you and I are very familiar with the abysmal recidivism rates, which shows that
Mm-hmm.
that's not the approach. And
Mm-hmm.
often leads people to have more problems once they get out than they were facing when they went in. And treating people who are suicidal as criminals, I think, is the absolute worst approach that they can take.
Yeah.
And I just, I really struggle with the people who are so resistant. And the other way that they could look at it is it's saving it's making available the strictly law enforcement uh, personnel for circumstances that require their attention.
Mm-hmm.
And
That's
we
right.
also, in respecting law enforcement, because I've known there in different places that I've worked, I've never been so glad to see somebody in my life as when a police
Mm.
officer showed up. But then there's also been cases where I thought, oh my God, why did they do that? I had this under
Sure.
control. And we really expect there's such high levels of expectations on them, and they don't
Yeah.
have trainings to deal with so many circumstances.
Yeah.
And this is a perfect example. I would think that people should and would be very grateful to have this added resource. So that is, I think, reflective not of society in general, because it's not
Mhm.
police officers making those horrible comments in the newspaper. Um,
And I think some of the folks that feel that way is because we still have such a long way to go in terms of the education about what mental health and behavioral health disorders truly are. Um, even in things so small as how we talk about it. So, one of my good buddies is in oncology and palliative care. He's the chair of our regional hospital. His patients are not cancer. They have cancer. But we say, well, they're bipolar. No, they have bipolar disorder. They're depressed. No, they have depression. Well, actually, anxiety is the one, which is interesting because I think anxiety probably has made the most progress in terms of how we talk about it. They have anxiety, they have depression, they have bipolar disorder. Not they are their disorder. So even things that are so simple as that, going back to that was not who I was. That was the worst day of my life. Um, we're not represented by our mental illness. That's not who I am first and foremost. And I don't consider it any part of my identity. I consider it something that I live with, just like somebody who has fibromyalgia or asthma or diabetes. I'm going to have flare-ups. I'm going to have bad days. And it's incumbent on me to take care of that on a day-to-day basis and then make sure that I know I have the right people in the background. But we still have so far to go in general, not just in terms of law enforcement, but in general, on really making sure that the conversation is, how do we just take care of you because you have a disorder? Just like anything else.
And I love that because it's a subtle change in language, but
Mm-hmm.
it's so impactful. It
Mm-hmm.
really is. Allowing people to be identified as a person instead of an illness,
Mm-hmm.
And
And it,
as far as physical illnesses,
yeah,
cancer is one of the really big ones,
yeah,
You don't usually hear people talking about, oh, well, there's the pneumonia person, but for
yes,
some reason, cancer and other illnesses that have stigmas associated with them, they do
yeah,
that much more.
yeah, yep.
There's just a couple more
Um,
things that, oh, go right
oh
ahead.
yeah.
Go ahead.
One of the when I was working with the child adolescent population, we had a client who was in fairly frequently. And there was a lot going on. There was a lot going on for that young person. Um, but one of the things that I talked about after our couple of different clinicians had seen her a couple of different times, is I sat in and I was supervising at the time, but I sat in and I listened to the conversation. I kind of addressed some things and I finally said, I think a really important piece here is we need to start changing how you talk about your own suicidal thoughts and say, I'm having suicidal thoughts because I feel angry. I'm having suicidal thoughts because I feel sad. I'm having suicidal thoughts. Listen, Snickers knew a thing. You're not you when you're hungry. I'm having suicidal thoughts because I didn't eat this morning and I didn't sleep last night. And you think that sounds really reductionist. It is not. It is not. Something for somebody who's really struggling with a high level of mental illness, not sleeping well and not eating absolutely can trigger suicidal thoughts. So it gives the person the opportunity, instead of just saying, I'm suicidal. First of all, now you as an individual are suicidal, not you're having suicidal thoughts and they're happening to you. And what do you do about it? It's here's the symptom. Here's the problem. What do I need to do with the problem? Not what do I need to do with the symptom?
Right.
Mm-hmm.
And
I'm having suicidal thoughts because I feel lonely. I need to talk to somebody.
right. And that harkens back to the old classic study by Emil Durkheim
Mm-hmm.
of suicide, where for listeners who aren't familiar with it, he was looking for large scale structural and macro issues and their influence on something as personal and intimate as suicide. And
Yeah.
he he postulated that when the economy would get particularly bad,
Yep.
suicide rates would go up.
Yep.
But what surprised him, and it was an international study that's been replicated many times, but also when people are in situations that are extremely uh, wonderful, that
Mm-hmm.
are unfamiliar, he he put together this term anomie for normlessness. So
Mm-hmm.
that's why you see a lot of people, celebrities who have come from poverty and then
Mm-hmm.
now they are extremely wealthy. And you would think, why in the world would they possibly be acting out or taking drugs or making what's an obvious attempt at suicide? And Durkheim would say, they are kind of in a boat without oars. They don't
Yes.
have any sense of normality because
Yes.
all of their norms and expectations and roles have completely
Yeah.
changed.
Yeah.
And that is so immensely disruptive and disturbing to everybody because we
Hmm.
crave equilibrium and what we're used to. So I think that that really supplements exactly what you were talking about.
Yeah.
Uh,
Instability of any kind is still instability, even if it's
that's
good.
right. Yes, exactly. So I did want to ask for
Hmm.
those who are watching and they've got a friend or a loved one who is talking about suicide, but they're not as fortunate as you are that one of their friends is a psychiatrist.
Hmm.
Your friends are all lay people, have not been
Yeah.
to college, or if they were, they studied something vastly different.
Hmm.
So, what are some of the warning signs that the average person can look at, and at what point do you would it initiate some serious responses? Can you help us with
Hmm.
that?
So coming off talking about instability, I think that's a really important part. So you want to look for losses that are important for that person. Some people are going to leave a job and they'll be like, yes, I am thrilled to be done with that. Some people are going to leave a job and it will feel like their world has shattered around them. And they're going to tell you, you're going to see that. That counts also with long-term relationships, whether they're platonic relationships, romantic relationships, family relationships. Um, you mentioned economic change. If a person is feeling like, I don't know how I'm going to afford food, I don't know how I'm going to afford medical treatment, I don't know how I'm going to afford rent, and I can't certainly do all those three things. Sometimes people won't necessarily talk about feeling suicidal, but they may say, yeah, I don't know how I'm going to make it out of this. I don't know how I'm supposed to handle all of this. So those are big ones. A very important part is awareness if they have access to lethal means. Our most lethal means is firearms. I live in a rural area. You're not going to hear me arguing for we need to remove all firearms because some people have very healthy relationships with their firearms. They go hunt with it. They see it as a thing that brings them a sense of wellness. But with firearms, there needs to be a safe storage method. So whether it's a cable gun lock that goes through, making sure that ammunition is stored in this safe locked over here, and the firearm is stored in a different safe so they're not together. Even if a person is at a lot of risk, asking, is it okay if I take them out of the house? Are you comfortable giving them to anybody? Those are great conversations to have in the first couple. And I have had those conversations. The first couple of times that you ask somebody about that, it feels really uncomfortable, especially if you know that they have a deep, meaningful relationship with their firearms. But if you frame it just the right way, if you talk about, well, if while you're feeling this bad, do you think that there's something else that we can do with this so that it's not so close? Even can we take a picture of your happy place? Can we take a picture of your dog to the handle so that you have this moment that you have to stop and see something that actually you do love? Um, but also, do they have a lot of medications around? Do they talk a lot about, geez, I mean, we could go on and on about lethal means, but really having, do we know if they have access to lethal means? Some people are going to be suicidal and won't have a plan, but do have access to lethal means, and they can sort of develop that plan as the thing goes along. So that's a really big component. In terms of other types of instability, other types, you've heard me use the phrase during this podcast, hopelessness, feeling trapped, tunnel vision. And those are things that they'll be leaked out in conversation. You'll hear people talk about, I don't know how I'm going to get out of this. It's not going to get any better than this. What it is today is what it's always going to be. And when you hear somebody say that, and this is my own personal plug on hope, you don't say it's going to get better. My favorite example of this is on actual 9/11. I was crying, and one of my teachers came by and saw me crying, which is reasonable. I was raised like 11 miles from New York City, and there were kids in school who didn't know if their parents were coming home that day. She said, "Don't cry. It's going to be okay," which was a bizarre thing to say on any day in American history, to say, "Don't cry. It's going to be okay." That wasn't the one of them to use that sentence. If you hear somebody saying, "I don't think this is going to get better," don't try to slap a Band-Aid on it by saying, "It will." You don't know that, and it's not your promise to make. You're just asking, responsibly, why do you feel that way? Tell me what this looks like to you. So those are some of the warning signs. Any diagnosis of a new disorder, whether that's a physical or a mental health disorder, pre-existing mental health and substance use disorders are really big triggers. Anybody who has a change in their behavior in terms of like attendance to work, whether they're finishing assignments for school, like either they're starting to do everything perfectly all the time, which you sound like, no, that's improvement. No, they might be tying up loose ends, or they used to be very conscientious and they have totally dropped off the mark. Substance use, more than half of suicide deaths in the United States, somebody has a substance in their system. Alcohol, marijuana, cocaine, opioids. And of course, recently it's tough to really say whether the suicide risk or suicide death rate is expanding lower than anticipated, because the ease with which a opioid overdose can be called a non-suicide. Mm-hmm. So that's, again, conversation for another day. But that part of your brain that maybe when you're in college and you drink a little bit too much and you make out with somebody that the next morning you wake up and you go, "Oh my gosh, I never would have done that if I was sober." That same part of your brain that gets shut off in that moment is also the part of your brain that's shut off when you're thinking about suicide if you're under the influence. Presence and of active use of any kind is automatically a risk for suicide. Okay. And especially if there's been a recent change.
Uh-huh. And something that I have read, and I'd like to hear your thoughts on that, is that one of the big red flags is if somebody has obviously been very depressed and then all of a sudden they're in a much more elevated mood, that they, and the hypothesis is that they see an end because they've decided to take action. Do you agree with that?
Yes, that definitely is. And that when we talk about the changes in medication, adding a new one, increasing, decreasing, or going off are some of the most dangerous times in a medicated person's life, because exactly as you're describing, it gives them a little bit of a lift. And for somebody who's been in a deep state of depression for a long time, that little bit of lift can also give them enough energy to follow through on that plan that they've been considering for a long time. So there's two components of that, because the medication is distinct from what you've just described. But absolutely, those little lifts can be signs of not, "Oh, cool, we're good now," but rather they have made their peace, and that's not peace with life, it's peace with death.
Right. Okay. And then my last question is, if there is a completed suicide and you are a family or friend or some other loved one, it's very common for people to feel as though I'm clearly missed something. It's my fault. What type of support or advice would you give to people who have just lost somebody?
Little known fact, a lot of crisis units will do suicide postvention work, because we're unfortunately equipped to talk about it in a very fluent way. You can call your local crisis department and say, this is what has happened. It feels really hard. And so please know, if this is a loss that you have experienced, anybody out there, and you find yourself saying, I missed something, they wanted you to miss something. And not they as an individual, but their disordered brain wanted you to miss it. This wasn't something that they, as the person that you know and love, chose. The person that you know and love lost a battle with their illness in very much the same way that a person with cancer loses their battle with cancer. And even in that translation, a loved one may question, well, surely if I would have gotten them into more treatment, if we would have done XYZ thing. I'm going to both honor that experience as wanting to be able to take some ownership for it, because then you have some control over it. And we want to be able to believe that we can control things. And I'm also going to give you freedom from it. There's no easy suicide loss. There is no suicide note or non-note. There is no, we were told about it before, we weren't told about it before, that's ever going to make it easier to swallow. Where it comes to my loss, I will never know on this side of heaven what happened and why he felt that that was necessary. But over the course of 18 and a half years, I also recognize this isn't my battle to fight in this lifetime. And there's no easy words to say over that situation, because it's a traumatic loss. But talking with a therapist can help. Talking with someone who is familiar with suicide death can help.
Okay, so folks who have experienced this loss should certainly seek out some professional support in coming to terms with it, and maybe minimizing some of the guilt that they feel.
There are so many
Okay,
different grief resources, but yeah, even, and some people, sometimes it just helps to hear somebody who's also experienced a suicide loss go, yeah, man, me too. My personal suicide loss was of an unusual nature in that it was a murder suicide. And there are pieces to pick apart with that. But I one time responded to a crisis assessment for a young man whose brother had died by murder suicide. And I was able to speak with him about how complex that loss is. Sometimes just being able to say, I've been in the same boat with you, and I take nothing away from you about how hard this experience is, can make it easier to manage. Again, because this is how humans are designed neurologically.
right. Okay, and then just to finish up by providing some
Mhm.
resources for
Mhm.
our viewers. We talked about 911 and
Mhm.
the pluses and minuses of
Yep.
calling that number. You mentioned 211,
Mhm.
and many of our viewers may be familiar with the new resource of 988. Can you
Mhm.
talk about the difference between 211 and 988?
It's hard to give a real good answer to that question, because in some places 211 and 988 actually go to the same call center. Not all places, but some places they do. So 988 is the National Suicide Prevention Lifeline. If you're outside of the country, you can still call it, but you can't use 988. You have to use 1-800-273-8255, the talk phone number. You will be able to speak with someone who's trained in suicide risk and assessment about what's going on. And you can call in regards to yourself. You can call with questions just like we've talked about here. I have a friend who said XYZ. They can help give you a little bit of a script about how to talk with that person. Now, I will say you can also use the crisis text line. I think it's, oh goodness, I'm forgetting the civilian line. I apologize. I don't have that off the
You
top of
can
my head.
text to 988 too, I believe.
Oh, sweet. Okay, good. So that's a little bit different because there is a crisis text line, which is its own, it's actually its own separate resource. So there's a couple different resources that are available. I encourage anyone who is actively in treatment, even if it's, your primary care physician gives your medication, you don't have a therapist, ask them as well, because they may know something a little bit more local, or they may have an after hours line. A lot of places now have some after hours resources or day of resources that can be used. Walk-in assessments, walk-in mental health treatment is happening more and more commonly. So there can be a lot of different places to go. So if you already have a provider, or the person has a provider, go ahead and make sure that you have that number. Hey, is there somebody that we're able to call and get a same-day appointment to?
Okay, great.
Mhm.
Well, Dr. Rachel Drosdick-Sigafoos, thank you so much.
Thank you.
It's always a pleasure to speak with you, and I always learn something. And even when we talk about something as difficult as this, I
Mhm.
always come away, and I'm confident that our viewers are going to come away with a greater sense of understanding and what can I do to be as
Mhm.
responsible as possible, and also have realistic expectations and know that you
Yes.
can't fix everything.
Yep. So I always close every spiel that I give with the same affirmation, and it is not my knowledge, so I will give credit where credit is due. When I had begun working in the child and adolescent population, that I couldn't watch Law and Order Special Victims Unit anymore, because I went from thinking that this was something that happened every once in a while to realizing this is something that is happening, really at a high level every single day. I asked a friend of mine who was a retired state trooper, how did you do this? How did you do this work for so long? And he said, first of all, you have to know who you can have a sense of humor with, because a sense of humor is a way to let out a feeling in maybe a less vulnerable way. But he also said, so this is courtesy of Sergeant John Tom, um, you don't have to save the whole world. You just have to save enough of yourself to save a little bit of somebody else. And I always share that, because first and foremost, as people who are working in mental health or human services, or people who just are interested in the greater good, you maybe start to feel like you have to save the world. But what it really is, and I think this is beautiful wisdom on his part, you have to take good enough care of yourself that we can all partner together in this long journey of wellness and being connected with others,
Mhm.
so that you can give a little bit of support and you're not emptied out when that moment comes.
Great. That
Mhm.
that is wonderful advice. I can see why you make a point of sharing that whenever you have the
Yeah.
opportunity. He's clearly very wise. So
Yes.
thank you for being a guest. I'm very grateful, and if I can ever return the favor, let me know. And good luck on the new
Thank
career
you.
path that you're taking. And I look forward to talking to you again soon.
Thank you, Professor Spears. Take care.
Bye-bye.
Bye.